Introduction to Urinary Incontinence. This module is the first of several modules that go into differentiating between acute and chronic urinary incontinence, and then going into managing the different types of chronic urinary incontinence. Our objectives for this module include to discuss the causes of acute urinary incontinence, identify appropriate referral criteria, and distinguish between the types of chronic urinary incontinence, including causes and treatment. Urinary incontinence is defined by the International Continence Society as the complaint of any involuntary leakage of urine. It is a problem experienced by many people, some believing that nothing can be done, and others that this is a normally occurring phenomenon that happens as one ages. As you will come to see, this certainly is not so. Urinary incontinence is in fact a symptom of an underlying pathology. There are many management methods available that can cure or at least diminish the number of incontinent episodes the person experiences. Garnered from the year 2000 data, approximately $19.5 billion was spent on managing urinary incontinence, with most of this money going towards the management, such as the use of absorbent products or skincare. A quarter to half of the money was spent on diagnosis and treatment of the underlying problem. The cost to urinary incontinence is also more than spent on dollars. Individuals feel embarrassed and will isolate themselves and are at increased risk for falls, broken bones, and skin breakdown. So let's look a little more closely at the scope of the problem. To review a little terminology, prevalence is a picture or snapshot of a moment in time. It tells you how many people at a specific point in time have a condition as compared to the whole population being studied. Incidence, on the other hand, looks at the number or percentage of individuals who develop a condition or problem, in this case incontinence, over a specific period of time. Incidence data is a little harder to come by than prevalence data. Incidence and prevalence data about urinary incontinence varies according to the population being studied and provides information based on that specific population. It has been found that urinary incontinence occurs in the elderly population at a range of 25 to 50% for elderly women and 21% for elderly men. In the community setting, up to 43% of adults are affected, and in long-term care, the number can be as high as 70%. It is one of the major reasons for institutionalization of the elderly. A fall occurs, a hip is broken, and the individual is no longer able to care for him or herself at home. Families may be taking care of mom or dad and are no longer able to cope when the person becomes incontinent. Reasons for the higher rates of urinary incontinence in institutionalized individuals is attributable to dementia, urinary tract infections, medications, restricted mobility, and constipation. So why is the pregnancy data on this slide important? Those developing incontinence during pregnancy are at an increased risk for developing urinary incontinence later in life. For those with nocturnal enuresis, the incidence for those with no family history is about 15%. On the other hand, if both parents have a history of nocturnal enuresis, there is a 77% chance the child will develop it, and when one parent was enuretic, there is a 44% incident rate in the child. Incontinence can be broadly classified as either acute or chronic. Acute or transient incontinence is defined as a newly occurring urinary incontinence. It began recently and with an abrupt onset that is often related to an acute illness or injury. It is reversible with appropriate treatment of the underlying condition. There are several mnemonics that are usually used to help assist clinicians to remember the causes for acute incontinence. The mnemonics include diapers, drip, and toileted. Over the next few slides, we will discuss acute incontinence using the mnemonic toileted, as this is the preferred mnemonic secondary to the potential negative connotation with diapers or drip. Now let's take a closer look at the causes of acute urinary incontinence using the mnemonic toileted. The T stands for dry, thin, vaginal, and urethral epithelium. This condition is also known as atrophic vaginitis or urethritis. Continence is dependent in part on normal coaptation of the urethral walls. The softness and stickiness of the urethral wall has an effect on coaptation. A lack of or decrease in estrogen is seen in postmenopausal women as a common contributing factor to this condition. A decrease or lack in estrogen causes thinning of the urethral epithelium, which leads to loss of the mucosal coaptation. The loss of coaptation can result in increased urgency or the feeling of having to void right now, and in urgency, which is voiding often. This contributes overall to urinary incontinence. Atrophic urethritis is associated with urinary tract infection in institutionalized women. Atrophic urethritis is seen as an inflamed hypertrophic urethral meatus, and a trial of topical estrogen can be considered to help manage this condition. The O is for obstruction. This would be as a result of stool impaction or constipation. It's a common contributing factor, particularly for those with symptoms of urgency. There is not a lot of space in the bony pelvis, and the bladder function can be negatively affected from chronic rectal distension. The fecalith exerts pressure through the soft tissues and can worsen symptoms of overactive bladder or urgency, frequency, and low voided volumes. Severe rectal impaction can cause an obstruction at the bladder outlet with urinary retention. One needs to then assess bowel function, take measures to clean out any retained stool, and promote regular bowel elimination. This includes evaluating the individual's fluid intake and discussing measures to increase fluids as needed. I stands for infection of the urinary tract. This causes inflammation of the bladder wall and urethra. For those who have been continent, complaints of urgency, frequency, and dysuria are common. For those with pre-existing urgency, frequency, or mobility issues, incontinence can result. Patients report sudden onset or worsening of urinary leakage. In the elderly, a urinary tract infection may manifest itself with acute mental status changes, so screening for UTI in those with acute changes is an important assessment tool. One needs to screen those presenting with these symptoms with urinalysis and culture. Individuals may also have a fungal infection. The WOC nurse should be suspicious of this in the patient who has an indwelling catheter and recent antibiotic therapy, or women with concurrent vulvovaginitis. The L indicates limited mobility. In addition to having cognitive ability to recognize the need to void and a functional urinary system, one must also be able to get to the appropriate place for voiding and adjust clothing to allow for the full voiding process. Any limitation that impedes the latter two functions can result in an individual becoming incontinent. Think of those with arthritis who may not be able to manipulate door handles, buttons, or zippers. Individuals with walkers or wheelchairs may be unable to respond and move quickly enough to get to the toilet in time. This problem particularly affects the elderly population and may be improved by bedside commodes, urinals, toileting schedules, and clothing modifications. E represents emotional issues such as clinical depression and, in rare instances, sleep deprivation. With clinical depression, evidence suggests that the neurotransmitters that are required for good sphincter function, such as norepinephrine, become depleted, placing those individuals at a higher risk for incontinence. Additionally, the motivation needed to heed the call for voiding is lost. As the person becomes incontinent, this may add to the depression that the person is experiencing. The WOC nurse must be alert to the signs of depression and refer those individuals for appropriate therapy. The T stands for therapeutic medications or pharmacologic issues. This will include prescriptive, over-the-counter, and herbal agents. Medications can contribute to both bladder storage disorders or loss of urine, as well as emptying problems or urinary retention. Those categories of medications that most commonly contribute to incontinence and retention include the following categories. Calcium channel blockers, which have a relaxing effect on the detrusor muscle, can precipitate retention, but also contribute to constipation. Additionally, they cause increased urine production at night, leading to nocturia. Diuretics increase production of large volumes of urine at one time, while narcotic analgesics can affect mentation. Alcohol has both sedative and diuretic effects. Anticholinergics include drugs to treat psychosis, depression, gastrointestinal problems, and Parkinson's disease. They have the potential to produce urinary retention by their mechanism of action, which is decreasing bladder contractility. And they also contribute by producing sedation, constipation, or mobility. Medications with alpha-adrenergic properties such as phenylprine, also known as neosinoprine, increase urethral resistance, resulting in worsening urinary retention. Pay particular attention to the medication list for those who are elderly and those with multiple comorbid conditions, as any medications can have an effect on the urinary system. It may be beneficial for the WOC nurse to consult a pharmacist and discuss any concerns with the primary care provider. E addresses endocrine disorders. Everyone is familiar with the effects of diabetes mellitus with hyperglycemia, which creates large volumes of urine with the potential for leakage. A second endocrine disorder is diabetes insipidus, a condition in which the person produces large volumes of dilute urine. Assessment for urinary incontinence must include evaluation of comorbid conditions and their effect on the urinary system. The WOC nurse must work in conjunction with other members of the health team to control comorbid endocrine disorders in order to effectively manage urinary issues. Although not an endocrine disorder, be alert to those whose weight loss regimes includes excessive water or fluid intake. Finally, the D is for delirium. It's a reversible condition in which an individual's cognitive state has declined. It is important to differentiate between delirium or dementia. By definition, dementia is an irreversible decline in cognition. Additionally, delirium can be superimposed on dementia, resulting in sudden but reversible worsening of the individual's cognitive status. Delirium has a variety of causes, including some of the things already mentioned. These include medications, alcohol use, sleep deprivation, anesthesia reaction, electrolyte imbalances, and urinary tract infections in the elderly. Do a careful evaluation of the cognitive status, noting any sudden changes in cognition, then take the appropriate steps to treat the root cause of the problem. Two gerontologists, Dr. Neil Resnick and Dr. Joseph Outslander, advised mnemonics to help remember the causes of acute incontinence. The other two can be seen on this slide. Each of these areas is covered in the toileted mnemonic. The important thing is that you remember and assess patients who have urinary incontinence for these reversible causes. It's important to address the underlying etiology of the cause and correct it. Untreated, these acute or transient causes of incontinence can contribute to chronic incontinence. Now we will move our discussion to chronic urinary incontinence, or incontinence that is lasting. There are two overriding categories: storage problems and voiding dysfunction. Storage problems are further categorized as stress incontinence, urge incontinence, overactive bladder, which is many times referred to by the initials OAB, mixed, which is a combination of stress and urge incontinence, and urinary incontinence due to functional impairment, which we will shorten to functional incontinence, extraurethral or total incontinence, and nocturnal enuresis. Voiding dysfunctions that may or may not result in incontinence are retention, neurogenic bladder, also known as reflex incontinence. The most common types of chronic urinary incontinence are stress and urge. These two, along with mixed, which as you will call is a combination of stress and urge, account for about 90% of the cases of incontinence. Recognizing them and understanding the causes and treatment will help you have a positive effect on the patients you see and will help you recognize when to refer others for further workup or treatment. Another way of classifying chronic urinary incontinence is as storage or emptying problem. Storage problems are implicated in stress, urge, mixed, functional, and extraurethral, and emptying problems are seen in retention and neurogenic bladder as a combination of storage and emptying issues. The most important issue when dealing with incontinence is protection of the upper urinary tract. Restoration of continence or development of an acceptable bladder management program is the secondary goal. Over the next few lessons, we will describe each of the types of chronic urinary incontinence in more detail. This ends the first part of this module series. Thank you for your attention.